potentially help with pain. So we're looking at it and recruiting patients for cancer pain. It's not delivered through a pump, so that's very nice. It's delivered as a single shot injection, infusion, under anesthesia into the intrathecal space. So you think about cost. A colleague of mine from Utah did cost analysis for intrathecal therapy for cancer patients, and Shane Brogan showed that in the long term, intrathecal therapy is less expensive if you compare it with using brand name medications, such as a fentanyl patch that's brand name, such as our ultra fast acting fentanyl preparations, which are very, very expensive. It's intrathecal therapy in the long term is cheaper. However, compared to the very, very cheap medicines like methadones, generic morphines, it's not as cheap. So for those patients that you failed methadone, failed morphine, failed a lot of these different things and have side effects, maybe intrathecal therapy should be entertained as a consideration rather than starting them on the very, very expensive medications that we have available to us. So where are we heading? I only talked about the different therapeutic options in the pump, but there's new technologies out in the United States and Europe, and maybe even here. There's new programmable pumps. There's a patient bolusing device, so it's not just continuous infusion. They can give boluses on their own. And there's updates to the existing pump software. There's new medication options. Again, we're getting more and more targeted. I wish I could talk a little bit more about epigenetics, because our researchers, basic scientists, are looking at epigenetics and cancer pain as well. More toxins may be in the pipeline. We know resveratrol as well as monocototoxins. Different strategies with regards to dosing. Microdosing is really en vogue in chronic pain, and I've been using it in also cancer pain in the United States with very good success. So what about my patient Angela? What did I do? I put in a pump, and this is my formulation in her pump, and she's actually doing really well. MD Anderson sends marketing things around the nation, and they did a study, an article on her, and what they said is Angela believes she's earned the right to call herself a survivor. Yes, she is. She has cancer since 3 years old, and she had pain. My pain isn't completely gone, but the pump has helped it tremendously, keeping me in the classroom with my students and living my life. Again, our patients, they are people, and you want them to get back into their life as much as you can. So that's it.
Any questions?
Any questions? Okay, thank you, sir. Now we'll be proceeding to our panel discussion. For the panel discussion, we are privileged to have eminent faculty with us. First of all, I'd like to request Dr. Geeta Joshi, madam. She is the professor and head, Department of Pain and Palliative Medicine, Deputy Director, GCRS Ahmedabad. She is also the President, South Asian Region of Pain Society and past Secretary, ISSP. Welcome, madam. Our next panelist is Dr. R.P. Gedu. He is an eminent teacher, passed DA 1984, MD 1986 from VM Medical College, Solapur. He confirmed FICA fellowship last year. He is working as a professor in anesthesia in Tata Memorial Hospital, Mumbai. He is an examiner and paper setter for MD, DA, NB, PDCC pain examination. He has plenty of publications. He's been as a faculty, so many places. Welcome, sir. Next we have Dr. Joyshri Subramania, madam. She is in private practice in Dallas, Texas. She is trained in anesthesia at PGI Chandigarh, trained in USA at Columbia, and fellowship training at Cleveland Clinic, Ohio. Welcome, madam. And our last panelist is from Sri Lanka, Dr. Rohita. Welcome. He did his MBBS and MD from Colombo Medical School, and he is interested in management of chronic non-cancer pain. So I'd like to be more interactive in this session, and the theme is WHO ladder still valid after 29 years? So I'd like Madam to please give a brief introduction of the WHO ladder.
Yeah, in 1980, WHO introduced a National Cancer Control Program, and in 86 introduced a three-step WHO analgesic ladder meant for treatment of cancer pain. It is a more of a framework and principle-based recommendation of how to use the oral analgesics for treatment of cancer pain. So there are three steps. First step has where your patient for mild pain should be treated with non-steroidal anti-inflammatory drugs plus adjuvants. If the pain persists, you have to switch over to the next step, which where you introduce weak opioids along with the existing drug of non-steroidal anti-inflammatory and adjuvants. If the pain persists, you switch over to the strong opioids. This is the basic framework of the WHO ladder.
Sir, Kedu sir, I'd like to ask you, in Indian perspective, what do you think? Is the WHO ladder very helpful? What is your personal experience?
I think if it is a India perspective spacing, definitely it is the most useful one because it's a very simplified approach and basically it relies mainly on the oral drugs. So getting an intervention or rather when we are talking of tertiary centers, then it's fine. But what normally happens is patients come from remote places, almost 60 to 70% patients come from remote places. They are thinking of all these interventions or whatever are not possible. So I think for India concerned, this is the best one approach that has been available for us. I think for us at least it is very much valid. I'm not saying we should not change it, but even the standard WHO three-step ladder is also valid for Indian population very well.
Thank you, sir.
Yeah, it is very relevant in Indian setup mainly because of two reasons. In many places, morphine is not available. Where we have to do with the whatever drug available of step 2 like buprenorphine or fentanyl patch or the tramadol or whatever. Second reason why it is valid because when patient cannot tolerate morphine, then WHO ladder is still valid where we can do with the step 2 drugs available. And in Indian setup, when the patients are coming from remote places, they have to dependent on the primary health center and community health center for availability of the analgesics. So if those doctors or paramedics are trained in WHO ladder, they can give treat the pain better way with oral analgesics to these patients.
Thank you, madam. Whenever we think about cancer pain, the first thing what comes to our mind as far as medical treatment part is concerned is morphine. Whenever we read articles, everywhere it's morphine. I want to know why morphine is considered as the gold standard in pain management in cancer patients.
Yeah, morphine, firstly it can be very effective orally. The side effects which it causes are manageable with treatment or change in nutrition or water intake and also things. Thirdly, it doesn't have ceiling effect. Morphine doesn't have ceiling. You can increase the dose as the pain increases. And the pharmacokinetic of the morphine, even if the larger dose is given over a long time, it doesn't change. So it doesn't have combination in the body and patient tolerates it very well. These are the reasons why the morphine is gold standard. Because in cancer patient, the pain is likely to increase. If the cancer advances, pain is likely to increase, so is likely. Yeah. And lastly, as Dr. Redu has prompted me, it is the cheapest drug available in Indian scenario. Thank you.
Very true, madam. Redu sir, would you like to add something? Why do you think?
I think I already prompted us. She has already added.
Now we talk about WHO ladder, new and new articles are coming up, two-step technique or three-step technique, even fourth step is coming up. What do you think? We should stick to 3 steps, or two-step, or where you go for a low dose, high, strong opioids rather than a weak opioid. What do you think in step 2?
See, as far as the international standard, the way you are talking very correctly, they have already these are being stepped up to 4-step ladder. In fact, there is a lot of talk also being going on that shall we really stick to the step 2? Because step 2, there was a big meta-analysis of almost 73 publications where they say that step 2 is as good as useless because it's weak opioid with NSAID. Ultimately, majority of times, at least in the Caucasian population, and also think the converting enzyme is not there. So in those people, say codeine, which is the weakest one, it basically adds to the constipation, not to the pain management. So anyway, even if it is adding, but I think it doesn't cause a significance. So there are talks which have been going on where they say, is the step 2 really necessary? But if you consider that it being necessary as it is being WHO ladder, I think 4-step ladder where the intervention and so many other things which are lacking should be added, and I think it has been accepted also now worldwide. I think.
Madam, would you like to add something?
People have advocated some changes in WHO level, like introducing interventional steps. But as per our experience, intervention in cancer patients can be done at any stage, whether it is a patient is in moderate pain or severe pain. Since these patients are coming from far off places, whenever possible we do intervention, and then patient again goes home with morphine. Second change they have advised is you should address the psychosocial aspect. But WHO in its cancer pain guideline, apart from WHO analgesic ladder, has already recommended that all these patients should be evaluated for psychosocial problem, psychological aspect like depression and all, family support and all such things. So it is already covered. Third, people have recommended that there is no place for change in opioids, switching over the opioids. Of course, it is not mentioned, but if you see the wider, broader aspect of WHO ladder, they have mentioned only opioids. So any opioids on stage 4, step 3 is you can use it. So switching, there is a possibility of switching over to the other opioids. Unfortunately, in Indian scenario, we don't have much choice about the opioids apart from morphine and fentanyl patch. So these are the recommendations, but if you see the wider aspect and broader aspect of the WHO letter, all these issues are addressed in the WHO letter.
Thank you, madam. Now, when we talk about cancer pain, already on medical management, we always, think about and always come across breakthrough pain. So, madam, I'd like to ask you, what exactly is breakthrough pain and how would you manage it?
First of all,